Good morning, everyone. Good morning. Good morning.
Good morning, Chair.
I'd just like to make two announcements specifically for council members before we begin. Please make sure that you're in the proper meeting so that the voting can take place properly with eScribe. Otherwise, the voting functions won't work properly. And so today's order is community services, administration and finance, and planning and work. And then a special closed meeting. So try and stay in that same meeting. We've got two planned breaks today. There might be more if required, if we would need some advice on procedure. The first break will be at 12 o'clock to 12:40, which will include lunch. And then the second break will be at 4 o'clock for 20 minutes before we begin our special council meeting. So, good morning and welcome to our Community and Health Services Committee meeting. I'll invite Julie Hale to take the roll call.
Regional Chair Redmond.
Present.
Councillor Craig. Present. Councillor Deutschman.
Present.
Chair Erb.
Present.
Councillor Foxton.
Present.
Councillor Harris.
Present.
Councillor Hunick.
Present.
Councillor James.
Present.
Councillor Liggett. Councillor McCabe.
Present.
Councillor Nowak. Councillor Salonen will be just a few minutes late. Councillor Shantz.
Present.
Councillor Verbanovic.
Present.
Councillor Williams.
Present.
And Councillor Wolf. Thank you.
Thank you. As we begin this meeting, we are again reminded that many of our homes and places of employment are situated on the land that is the traditional territory of the Haudenosaunee, Anishinaabe, and Neutral people. We recognize and deeply appreciate the historic connection to Waterloo region, and we also recognize the contribution Indigenous peoples have made in shaping and strengthening this community. We are grateful for the opportunity to live and work here and reaffirm our collective commitment to keep the promise and the challenge of truth and reconciliation real and intentional in our region. Are there any declarations of pecuniary interest under the Municipal Conflict of Interest Act? None? Are there any? We have no presentations this morning. No delegations that I'm aware of. So what we'll then do is proceed to our regular agenda, item 6.1 under Health, Safety, and Inclusive Communities, a report on supporting healthy early childhood development, including a new Indigenous-led program. And I'll ask Dr. Wong to introduce that to us.
Thank you, Chair Erb, and good morning, councillors. I am pleased to introduce the first report, which provides updates on the Healthy Babies, Healthy Children program and introduces a new Indigenous-led Healthy Child Development program for First Nations, Métis, and Inuit families in Waterloo region. Regarding the Healthy Babies, Healthy Children, this is a program offered by public health units across the province. It provides support to vulnerable families who are expecting a child or have young children. It is a prevention-based upstream program to help children get their best start in life. Regarding the new Indigenous-led program, I am incredibly pleased to welcome and introduce our new partner, the Southwest Ontario Aboriginal Health Access Centre, or SOAC in short, Janet McCreary, Manager of Healthy Babies, Healthy Children, and Charisse Sayer, Integrated Care Manager with SOAC, have been working together. They're right there in front of you. And they have been working together over the last year to consider how to provide culturally appropriate support to First Nations, Inuit, and Métis families in regards to early child development. And I'll now pass it over to Janet and Charisse to provide their presentation. Thank you.
Good morning. The most critical time of human development occurs prenatally until a child is 6 years of age. The support provided to a child during this time frame provides the foundation for lifelong health. It is the most economical upstream time to invest in healthy human development. Today I'm going to highlight a little bit about the Healthy Babies, Healthy Children program, or HBHC. It's a prevention-based upstream program that encompasses consent-based screening, assessment, and home visiting to support healthy early child development, parent-child attachment, and positive parenting. The goal of HBHC is to support parents in building the foundation for lifelong health for their children. HBHC was deemed a critical service that continued to be delivered throughout the pandemic. Next slide. So the HBHC program supports families prenatally, postpartum, and in early childhood. And I'm going to briefly walk you through the process or the journey that a family takes through the program when their baby is born. A public health nurse will complete the HBHC screen with the family at bedside, in the hospital, or by phone for families we don't see at bedside. This is our universal consent-based contact with new parents. Our goal is to screen 100% of families and work with hospitals, midwifery practices, and family and children's services to support completion of the HBHC screen. An in-depth assessment, usually in home, is offered to families who receive 2 or more at-risk responses on the HBHC screen. Following the assessment, those who would benefit are offered home visiting with support from a public health nurse and a family visitor. The family determines their healthy child development and parenting goals for home visiting, and the nurse and family visitor support the family in meeting their goals. Next slide. In 2023, we will begin to collect demographic data for families who consent. We want to support our capacity to better understand who is participating in our program and who is not. We can then work on strategies to ensure we are supporting all families who would benefit from home visiting. Next slide. What I'm really excited to talk to you about is this partnership that we have between the Healthy Babies, Healthy Children program and Southwest Ontario Aboriginal Health Access Centre, or SOHAC. And it's developed to support, in support of the Truth and Reconciliation Commission call to action number 5 to develop culturally appropriate parenting programs for Indigenous families. The goal of our partnership is to create a new Indigenous healthy child development program that is culturally safe, trauma-informed, and provides wraparound care for Indigenous families with young children in Waterloo region. The partnership and service model is consistent with the Community Safety and Wellbeing Plan. Funding is provided through the Reconciliation and Equity Fund from the region. And I'd like to introduce Charisse Sayer from SOHAC to talk about the development of this initiative.
Thank you. First of all, I'd like to acknowledge Janet, her team, and the region for your response to Truth and Reconciliation Commission Call to Action number 5. Through this work together, we are renewing and establishing relationships based on principles of mutual respect and shared responsibility for maintaining our relationship into the future. If you haven't had an opportunity to review the 94 calls to action, I encourage you to do so. Far too often, the reins are not passed to Indigenous-led agencies and advocates, or historically, the reins were taken from Indigenous agencies. This partnership supported SOHAC staff to lead our community in conversation. We met one-on-one and in circle with other Indigenous service providers, parents, caregivers, aunties, uncles, grandparents, elders, and knowledge carriers. Honoring reciprocity, we gathered knowledge, experiences, and wisdom to create a summary document from this Indigenous-led engagement that outlined very clearly our Indigenous community's desired approach to creating an Indigenous-led healthy child development program. Indigenous healthy child development is a culturally safe, trauma-informed program that will provide wraparound care for Indigenous families. SOHAC already provides an integrated and holistic model of care, including primary health, mental wellness, and Indigenous traditional healing. Our team is excited to welcome the new program. We know and understand advocacy and navigation support is important to our families. It was strongly recommended that family visits and connections to hospitals be grounded in culture, language, and intergenerational connection. A few key points outlined in the summary include culturally grounded care, support for the cultural and spiritual health of families, and a sense of belonging and identity. Thank you, and miigwech.
We will take questions if there are any for us.
Do you have anything more to add, Dr. Wong? Or no? Okay. Are there any questions from committee members? Councillor Foxton.
Thank you, and through you, Chair. Great work, ladies, and well done. I was looking at this, and then yesterday with Chair Redmond, we had the opportunity to go to the University of Waterloo Eye Institute, and they talked about the program where they test the children in school at a very young age, and they also go to Recovery House to test the new immigrants so that everybody's eyes are being taken care of. And I thought, as I was listening to you and reading this before and then at the Eye Institute, I thought this is what upstream is, and this is what the start of reconciliation is. And so I congratulate you both, and thank you very much for this.
Thank you.
Chair Redmond.
Thank you, Chair Erb. And just to tag on to Councillor Foxton, it was very exciting to have these incredible researchers and professionals at the University of Waterloo give a shout out to our public health and the kind of collaboration and communication that they have with newcomers through reception houses as well as through the school system. I am so enthralled with the introduction and the participation of SOHAC in this. But when I think back, it all started when we were looking at the vaccine rollout and how we could provide vaccine clinics that were culturally sensitive and appropriate to Indigenous people. And I wonder if you can just talk a little bit about how that brought us to this point, because my SOHAC isn't new, but I think your entrance to this degree in Waterloo region is really significant. And in my knowledge, that was sort of the entryway. I wonder if you could just comment on that.
Absolutely. So the vaccine clinic was already in motion when I came on board almost 2 years ago with SOHAC. So SOHAC has been in the region supporting Waterloo Region and Wellington County for a little over 2 years, but has been in existence over 25 years across Southwest Ontario, just to give you a little bit of background on SOHAC. However, our director, Dave Remy, worked very closely with the region, public health, to open up a mass vaccine clinic along with an Indigenous nurse as well as other supports to provide culturally safe access to vaccines as well as education. There was a lot of apprehension from our community to seek vaccination, and it was really important to provide a safe space, but as well as that important education around vaccinations, whether or not they decided to get it or not. But that's how that partnership began, was with the region and Dave Remy.
Thank you. And if I could just a footnote, Janet and I ran into each other around Christmas, and I have to tell you, I have very rarely seen somebody as excited about a new development in a program. So clearly this is a passion project for you as well.
Absolutely. Thank you.
Any other questions? Well, thanks for this presentation. It's encouraging, great news, breaking down more barriers, and truly, as Councillor Foxton said, upstream work. So thank you for the work that you're doing, and continued success.
Thank you very much.
So committee, that was for information only. There's no action required. We'll now move on to agenda item number 6, 1.2, the a report on the Waterloo Region Integrated Drug Strategy. And again, I'll ask Dr. Wong, the Commissioner, to introduce the report.
Thank you, Chair Erb. So I'd like to first start off by thanking all the members of the Waterloo Region Integrated Drug Strategy, also known as the RIDS in short, who have come here this morning to provide Regional Council an overview of the RIDS work. I'll be introducing the speakers shortly. The RIDS is a voluntary collaborative of multiple partners across several sectors, working together to reduce the harms associated with problematic drug use. As there is no single organization mandated or funded to work on all areas of a community drug strategy, working together achieves better outcomes than working in silos. While public health units have been given a role by the province to provide support to evidence-based harm reduction initiatives, the key to a successful community-based drug strategy is a multifaceted approach, including the the clear need for adequate treatment and recovery services, which are funded by the province. The purpose of the presentation and staff report we have in front of you today is to provide one, orientation to the Waterloo Region Integrated Drug Strategy, or RIDS, and two, share updates on the work being done by public health staff. Today, you will be hearing from the chair and coordinator, respectively, of the Waterloo Region Integrated Drug Strategy, Eugene Fenton and Erica Poulin. As well, Michelle Kennedy, Addictions Services Director from the House of Friendship, will speak about the Rapid Access Addictions Medicine Clinic that they operate. And finally, from Leigh Wardlaw and Violet Imanats from Sanguine Health Center, they will speak about the Working to Improve Neighborhood Safety, or WINS, project, as well as the Consumption and Treatment Services site that they operate. Before I pass it over to Eugene and Erica to begin the RIDS presentation, there is one update included in the report I would like to draw your attention to. On February the 1st, 2023, Public Health launched an overdose drug poisoning dashboard. This dashboard will provide timely access to local data to inform staff, community partners, and the public about drug overdose and poisoning-related events in Waterloo Region. Thank you, and I'll pass it over now to Eugene and Erica.
Thank you, Dr. Wong. Good morning, Chair Erb and members of council. My name is Eugene Fenton. I'm a Deputy Chief with the Waterloo Regional Police Service, and I'm also currently the Chair of the Waterloo Region Integrated Drug Strategy, or RIDS, as we're referred to. Today, joining me is Erica Poulin, the coordinator of our strategy. The RIDS is a region-wide collaborative response to address substance use and its associated harms. Substance use is a complex individual and community issue. Potential solutions go beyond the capacity of any one organization or system. The RIDS facilitates the opportunity to address problematic substance use by bringing partners together who work across multiple sectors. I will now turn it over to Erica, who will bring you through some of our history and our path forward. Thank you.
Thanks, Eugene. Can we go forward? I think one more slide. Yeah, perfect. So I'm going to begin with a little bit I'm going to begin with a little bit of a history of the drug strategy. So the drug strategy came about in 2011 as a result of a community consultation conducted by the region's Crime Prevention Council. The result of this consultation was the original drug strategy document, which contained 99 recommendations for addressing substance use needs in the community. And these recommendations spanned across 4 pillars. So in order to actionize the recommendations contained in this report, the RIDS, as a collaborative of community organizations, was brought together. So on the previous slide and this slide is some examples of RIDS work. We wanted to highlight in on 3 specific examples of ongoing and recent work. So if we can go to the next slide. So the first example would be the overdose monitoring alert and response system. So this is responsible for the community drug alerts you may have seen gone out. We've had to put out 2 already in this year, but this is a way of leveraging community knowledge to provide local and timely updates on the nature of the drug supply in the region. Another example would be assisting in the coordination of community partners to plan events for International Overdose Awareness Day in August. And then a third example would be the 2022 position paper on drug policy solutions that was put forward to the previous regional council that helped inform the endorsement of decriminalization of personal possession with expanded access to health supports as a drug policy position. So next slide, please. So to get a little bit more into the actual structure of the drug strategy, as I mentioned, the strategy takes a 4-pillar approach. So the first pillar being prevention. This refers to work that seeks to prevent or delay the onset of substance use, specifically by addressing root causes and taking a social determinants of health lens. Next, we have harm reduction. So this pillar deals with programs and policies that seek to reduce the health, social, and economic harms that can be associated with substance use. And what's important here is this takes a person-first, client-centered, non-judgmental approach without the expectation of cessation of use, and instead meeting people where they're at to find personally suited goals to help reduce harm. The third pillar is recovery and rehabilitation. So this refers to programs and services that improve physical and emotional well-being for people who use or have used substances. And what I want to highlight here is treatment is just one part of recovery and rehabilitation, but recovery and rehabilitation actually encompasses a wide range of really important supports tied to the social determinants of health. This might look like things like housing supports, vocational supports, counseling, kind of all of the wraparound care that people need to maintain personal recovery and rehabilitation goals. And then finally, we have enforcement and justice. So this is addressing crime and community disorder related to substance use, and specifically being able to shift the lens to a broader social determinants of health focus. So in terms of the actual structure of the RIDS, we've gone through some changes since 2011. Originally, it was a committee structure with pillar committees, but we've recently shifted to a project-based model, which we hope will make us able to do kind of more action-focused work. And our current priorities are anti-stigma and housing, but these are obviously open to change based on community need. But overall, even with these structure changes, the fundamental principle remains the same, that the RIDS tries to serve as a comprehensive 4-pillar approach to coordinate a variety of partners in the region to leverage overlapping interests, knowledge, resources, and skills towards collective goals. So that's it for me. Michelle was not able to join us. When we go forward in the slides, we're actually going to jump to, oh, sorry, one more slide if we go back. This slide, sorry. This one, yeah. So this slide just provides a brief overview of some of the partners that are part of RIDS and some of their individual agency work that they do to support the community, but this is by no means comprehensive. So now I will pass it along to Sanguine.
Hello, council members. So next slide. One more? Nope, next. Sorry. So working to improve, sorry, my name is Lee Wardlaw. So working to improve neighborhood safety. The WINS program is a peer-based needle program, needle recovery and harm reduction outreach program. WINS is a partnership between Sanguine Health Center and the region of Waterloo Public Health. WINS was initially piloted in the city of Cambridge from 2018 to 2019. The program was expanded to the city of Kitchener and Waterloo in 2021 as a 2-year expansion pilot. Next slide. The objectives of the program are to reduce the number of discarded needles in the community, increase meaningful employment opportunities for people with barriers to traditional employment, educate people who use substances of proper disposal options, and create a positive community response and increase community engagement related to harm reduction in substance use. I think that's all the slides. And I just wanted to speak sort of on the human element of the program. So the people we see applying for the program are people who are living in encampments and those that are living homeless or precariously housed, who want to be a part of the traditional employment, but due to many barriers, it is an uphill battle for most. We provide a judgment-free space for those who are interested in the program and provide them with the necessary education that they need to fulfill the role as a peer outreach worker. The WINS program provides not just low-barrier employment for our peers, but there is also the education piece to the program. We have been able to provide our basic harm reduction, Hep C, HIV, and naloxone training, mental health first aid training, and CPR for some. We also offer basic resume building and sitting with those who have never used a computer before that are wanting to learn more about them.
The WINS program also offers extra support for our peers with finding any community support as needed, referring those that want mental health addiction support through the proper channels. There have been many peers that have come in that have never worked a job or haven't worked for an extended period of time. The WINS program is meant for those who have mental health issues and those who use substances, who may or may not struggle daily, but want to be productive, but due to barriers of the traditional job will fail quite quickly, and that spiral of shame takes over. The WINS program allows for the extra support needed to work towards being on time, taking pride in job performance, taking pride in work being done, and being praised for it. I have witnessed many peers come off the street wanting to work, but struggle with being accountable to the job initially with multiple absences, difficulty getting to work on time, lack of communication, and just very low self-worth. With the support that is provided with the program, I have seen peers with time make the effort to come to work on time, decrease absences, communicate their struggles, and ask for help when needed. I have seen peers take pride and excel in the job that they are doing, which helps foster confidence, self-worth, and overall well-being, and knowing that they are appreciated in the community. And knowing that they are appreciated, sorry, I already read that, member of the community, and that they are getting the chance with this program. The program is much more than just picking up and properly discarded needles. The peers provide education to our community about what we do: harm reduction, safe needle disposal, naloxone training, attending overdoses, supporting and advocating those in crisis, and referring to them to needed services, and just being a listening ear for those we meet on our routes. Peers will also carry clean supply and sharps containers and snacks and water for those that we see on our routes. In my 2 years with the program, I observed people who have walked through the WINS doors that have never had employment or have been able to work for an extended period of time that absolutely thrive within the program. WINS helps to find each individual's strengths and weaknesses, and just helps to foster and build life skills.
Thank you. One more then for the presentation before we deal with questions. Is that okay?
Yeah.
Violet, were you going to, you're next? Okay.
Good morning, everyone. I admire people who can come up here and speak without notes and stay within a time frame. Anyone who's ever heard me speak on anything knows that I will stand up here for 3 hours and tell you everything I've ever heard or known or experienced. So I'm going to read very closely from my notes on this. I think there's a slide a couple back. That might be me. Going one more. There, one more back. There we go. So for the past 3.5 years, it has been my privilege to manage the CTS site for our community, working with a dedicated, highly skilled, multidisciplinary team that includes nurses, social workers, support workers, administrative coordinators, and outreach workers. As part of our region's drug strategy, the CTS is a healthcare facility with very clear federal and provincial requirements for our operation. It is also a place of safety and respite, a place where people who use drugs are treated with dignity and respect and genuine care and love. Next slide. You can see on the slide that there are a number of bullet points that identify the activities at the site, the things that we do there. And honestly, it makes me laugh a little bit to see it in point form, because the reality is that this is a summary, of course, and doesn't remotely capture the complexity and intricacies of the work that's being done there every day of the year, including all of the holidays. To be clear, all of the services that are listed here are tailored to be low barrier, trauma-informed, and specifically adapted to the unique needs of people in our community who use drugs. Next slide. Since opening in 2019, the number of visits to the site has steadily increased, and in 2022, as the COVID restrictions finally lifted, we were delighted to operate at full capacity. As you can see, we often have more than 1,000 visits in a month, and in December, we had just over 1,300. This speaks not only of the services, but also the relationships, the trust, and the care that's provided. People don't go somewhere that doesn't meet their needs. And they need to impress upon you the reality of that. Clients who report that the site is one of the few places where they are treated like humans and where they have value. This is both heartbreaking to me, but it's also very affirming of the work that's being done. Next slide. Since the site opened, we have managed and reversed almost 900 overdoses. That number is staggering to consider in terms of the lives we could have lost. I watched the team in action when I'm at the site, keeping someone alive, restoring their breathing. The work at the site removes a heavy load from the larger healthcare system and our EMS. There's a significant cost savings associated with community-based healthcare. Equally important, however, to me, is that it prevents endless grief and trauma to families and individuals in our community. And when there is trust and care, empathy and acceptance, there's also opportunity for growth and change, and we see that too at the site. It's not only about keeping people alive, although to me, that is the most important piece. The site is not a starting place, but a starting over place for many people who have felt lost, hopeless, disconnected, and shamed. And the value in supporting people in moving forward with that is extraordinary. And as I noted, I could say so much more for many hours, but I will just leave you with the gratitude from myself and from my team. Thank you.
Thank you. We love hearing what you're telling us. That's very inspirational. Thank you. I have some questions from Council. Councillor Foxton.
Thank you, and through you, Chair. Your job is difficult, but I want you to, all of you in this room, because all of you serve the people. Imagine if you weren't here. Imagine what would happen to society if you weren't here. And maybe you can't save them all, but for one moment in time, you might have touched everyone's heart. And you are invaluable. We appreciate so much for what you're doing. Stay strong, because I know it's hard on you. I know it bears on your soul, but you're making a difference. If you couldn't save a life, at least you showed compassion and love to a life, something they may not have had. So thank you so very much.
Councillor James.
Hi, it's through you, Chair Erb. Thank you very much for your presentation and for the work being done. I just have a question. The PowerPoint presentation referenced in 2022 developed a drug policy solution position paper. Is it possible for council to get a copy of that? Might have been presented to the previous council. Not sure how
I'll maybe just,
Yep.
I'll answer
Dr.
yes.
Wong?
So yes, it was presented to the previous council, and as a result, council passed a motion in support of decriminalization with additional supports from the federal and provincial governments for a number of things, including treatment services. So that was the result of that recommendation from the RIDS.
Okay, can we just get a copy of that at some point?
For
Thank
sure.
you. All right, thank you.
Sorry,
I
yeah.
just have one follow-up question for the team. In terms of safe supply sites, how many are there currently within the region?
Someone, Dr.
Yes,
Wong?
yes. Maybe I'll start, and then. Oh no, please come forward. Just yes, I'll just. So that is a safer supply projects are pilot projects that are funded and approved by Health Canada, and organizations can apply to run them on a pilot basis with evaluation to be done under Health Canada, and so. There is one site in our region that has been successful in receiving this pilot funding, and I'll turn it over to. I think there's a coalition of organizations that are working together on it, right?
Good morning, members of council. I'm Lindsay Sprague, and I support development of programs with Sanguine. We were fortunate to receive funding from the federal government in 2021 to operate a safer supply program within Sanguine. So our funding was actually just extended for another year until 2024 from the federal government. So we operate a safer supply program. It's being piloted in collaboration with the Working Center, and currently we're operating in the Kitchener region. I'll just let you know that we currently support 150 people through our program, and it involves providing clients with a safe, regulated supply of opioids for those who have experienced barriers to other forms of treatment. Thank you.
Thanks, Lindsay. Councillor Shantz.
Thank you. Thank you for the presentation and outlining all the good work that's happening. You spoke on a very systemic level about the things that you're doing. I wonder if, and without, saying things or sharing something that you shouldn't, is there a very exciting success story that inspires you? And not everyone will be here all day, but just if one of you has one that you would feel free to share, and if you don't, that's okay.
Any takers? Violet, you seem to have some...
On all of them, all of the stories. It's interesting because I've always viewed full recovery as an end goal. For a long time, I saw someone who used substances, and then I had this goal that they would be, living life abstinent and doing whatever they needed to do in life. And the complexity of humans is, makes that almost impossible in some cases. So incremental change is huge. Speaking only for this site, often people come in, it's their first visit, they're nervous, they're scared, they don't know what to do, they're not really speaking to us too much. They come in, they leave very quickly. It can take months to build trust. It can take months before someone wants to tell us their name. And so the day we find out someone's name and we can greet them by name when they come in is phenomenal. Like, that is a huge step. From there, getting to know someone, asking them, what brings you here? What can we do to help you? Often it's things like, I just need something to eat. Can you tell me what shelter might be open or where I can go? And again, they're asking for help. They're being vulnerable and asking us for something that we can support with. Often from there, we start to delve into what led you to this place. Your substance use, what brought you out into this community, why are you experiencing some of the challenges that you're experiencing? And again, that can take so long for someone to trust us. But I think the biggest success sort of across the board are those moments when someone comes in and we don't know them, they're a complete stranger, and several months later we know their name, we know their story, we know what their hopes, their goals, their dreams are, and our team can start to put together a plan for that person, with that person, to figure out what that is. And often, like I said, those are the little tiny things that someone really, really values that we look at and say, well, that's not a big deal. We can do that. Easy peasy, no problem. And then we just start to see that person bloom. Like, they just start to flourish. They start to connect. They might join WINS and work with Lee, for example. So they start to find their place. They start to feel like they are part of our community and part of a bigger picture. And that happens over and over and over again. I think we have about 200 unique clients that we see sort of spread out. And at least 50% of them, that's the situation. And in 3.5 years, it has taken 3.5 years in some cases for people to get to that point of being open and honest with us about what they need. But once we're in that position, it is beautiful. That's not really a story. That's not really a person, but it's a blanket statement of so many people wrapped into one. So it's beautiful.
Thanks for sharing.
Councillor Deutschmann.
Thank you, Mr. Chair. Can you hear me okay? Can you hear me? No?
Yes.
Okay, great. Just want to double check. Hello. First, I just want to thank Sanguine for their work, and I hope the recent news and about the loss of funding can be resolved, because we need Sanguine and the services they provide in our community. Our region would be in dire straits without their services, and while the feds and province need to step up its financial support in our communities, the region needs to support Sanguine where and how it can. And so I want to thank them for their service that they provide. My focus, though, is on RIDS itself, not Sanguine. And with respect to RIDS, I took a look at your website, and I'm just wondering if I'm looking at the wrong website, because the information on the website by internet standards is somewhat ancient. There's a lot of old references to programs, to position papers, there's nothing really current there. So can someone explain to me, that's my first question, is can someone explain to me what's going on with your website?
Do you want to respond to that, Eugene?
Good morning. Through you, Chair. Yes, thank you, Councillor Deutschman. So we are in a period of transition. So we've just taken on a new coordinator in the last 2 months. So we are in the process of updating all of those things. So stay tuned. We will have some enhancements soon.
Yeah, hopefully you will, and I will for sure. So I thank you for that. With respect to the recent dashboard, February 2023, is this similar to what you had on there called OMARS, an overdose monitoring alert and response system? Is it different, or are you just picking up where it got left off?
I'll let Erica answer that, or perhaps Jonathan.
Good morning. My name is Jonathan Mall, and I'm a manager in the Healthy Living and Foundational Standards Division in Public Health. The OMARS alerts are different from the dashboard. The dashboard is a combination of various data that's provided to us related to overdose drug poisonings, and that dashboard, that information is collected together into the dashboard, and it's newly launched. OMARS is the overdose monitoring response system, which are alerts that are sent out when there is concerning drugs that are in the toxic drug supply, or if there is a certain number of overdoses that have occurred, and an alert is triggered and distributed. So they are two different pieces. One of the things that we do is we post the OMARS alerts on the RIDS website, so you will see the most current OMARS alerts on the RIDS website.
Thank you. Okay, next on the list is Councillor Craig.
Well, thank you, Mr. Chair, and I just want to state off the top that I do really appreciate all the efforts that we're hearing about today. And I don't want you to view my comments as being particular to the efforts that you're doing and what you're doing on a daily basis. But my concern is the overall number of deaths in the region year by year, which average about 120 overdoses. And I think that's that's an awful statistic. So in the last 5 years, we've had over 600 individuals die from overdoses. And if 600 people died at roundabouts, there would be a big, huge outcry in the region. No question about it. So we need to do more, and I'm in total support of doing that. If I look at the safe injection site, and I'm going by the report, the feasibility study of 218, which I think is an excellent report in terms of all the information that it provides. But what it states in there is that there are 4,000 people who have addiction issues, and 2,000 are injecting daily. Safe injection site's only seeing, what, 30 to 40 people. So my concern is, how do we deal with this issue of the other 2,000 people that we're not dealing with? How do we deal with the people who are the majority dying in residence? How do we deal with the people who are smoking crystal meth are not allowed into CTS sites? And I'm not trying to point the finger. I'm just bringing up those issues that are here in the document, that are out there publicly. And how do we, why are we, okay, I'll go on just with that. I'll leave that little bunch with you right now. How do we deal with these? Do we need to have a more expanded view? What do we need?
Thank you, Councillor. Through you, Chair. So I'll start and try and answer a bit of that. So I think the answer, RIDS as an entity and an organization in the position paper that Councillor James mentioned, supports the concept of expanded access to CTS in concert with a multitude of other prevention and treatment and recovery tools. So I think part of your answer is we have one CTS right now. I think obviously we could access more or help more people if we had more access to CTS. Also in that call was an expansion. You mentioned smoking crystal meth. There was a call for expansion and of inhalation services at CTS, because that is a barrier right now. So I don't know if Violet, you want to add on the ground any view on how we could get further?
I think you, sorry. So I think there's multiple pieces there. Yes, we need to expand CTS operations as they stand. Currently, it's 9 a.m. to 9 p.m. As I said, 7 days a week, 365 days of the year. But the reality is substance use is a 24/7 thing. Not everyone, works within those hours. So the number one request that we receive from clients is expand your hours. Make it available when I am using my substances. I want to use them safely to be there. So that we piece number one. The second piece, absolutely, inhalation services are something that are incredibly needed. The overdose risk from inhaling substances from smoking is the same as injection. And for many years, we have promoted inhalation as a safer method of substance use, not because of a decrease in the potential for overdose, but because of the decrease in health risks associated with injecting into veins and the systemic issues that can cause health-wise. So we do see people taking that opportunity to move over to smoking, and it is of huge concern that our site is not able to accommodate people who are smoking their substances. We know that puts them at risk for overdose. When we look at where some of the overdoses are happening outside of this site, I mean specifically, we do see private homes, we see residences, we see hotels, things like that. Part of that is access. If you think about someone who goes to a bar to drink alcohol, for example, versus drinking at home, often what they'll say is, it's too far to get to the bar. It takes me too long to get there, so I'm going to socialize with my friends and drink at home. Sometimes that's where that overdose risk is coming from. People in that feasibility study identified how far they were willing to travel by foot, by bus, by bike, and that's how we determined where we were going to place the current CTS to put that site, was to make it accessible. For people who don't live within that range, that's a huge barrier to getting there and to leaving. We can't allow people, for example, to drive to the site, use their substances, and then leave in a vehicle, because they're considered impaired at that point. So that's a barrier for people. Another barrier that we see is the stigma. And I know that we're all working really hard, especially through the drug strategy, to reduce the stigma. But what we've heard from people is, I don't want people to know that I'm using drugs, so I'll use them alone in my bathroom. And that's not something that any of us can remedy in the sense of a CTS or any of the other services, other than, again, to work to decrease stigma, to help people understand what comes, where substance use is coming from, how addiction forms, how it is kept, and all the things that keep somebody in that cycle. So that's another piece of that. I don't know if I even answered any of that, because as I said, I just get up here and I ramble.
I'm not trying to put you on the spot.
No, it's
And again, I come back to the fact that I appreciate what you're doing. I just have a much more, I think, expansive view of what I see. And if I may, just continue with this. One of the programs in here, and I forget the name for it, where they have an injection site at specific locations within facilities. One roof's an example, KW, Y, I believe, and I think the working center downtown.
Yeah, so urgent public health
That's where
needs.
the hot spots are. But there are all kinds of other hot spots in buildings and institutions around this region. Talked about some of the shelters as an example, okay? We know this, and we're not talking about it. Why not pursue that rapidly and now, as opposed to waiting for another CTS site? Would you advocate for that?
I would, yes, but.
Okay, well, that's good. Well, I'm just saying the strategy's not working.
I just want to make sure we're dealing here with questions of the delegations.
Well, it is a
not.
question, Mr. Chair.
Okay.
Why aren't we dealing with this?
I think what you're describing is the urgent public health needs sites, which is it's an application process to Health Canada where you can get an exemption to the Controlled Drugs and Substances Act to allow for substance use to happen on site. Unfortunately, the limitation to being approved as an urgent public health needs site is that it doesn't come with funding. And as Violet described, inhalation services is one of the methods of consumption that is not available at the CTS site due to limitations in the funding. The ministry won't fund that, and does require appropriate modifications to be made at the site. And urgent public health needs sites don't come with funding, and they wouldn't be able to as well. So that's a limitation, is that that inhalation services aren't available. And we do have 3 urgent public health needs sites currently. I do know that some of the other shelters and locations are interested to become urgent public health needs sites, but providing those opportunities is helpful.
Okay, I'll stop there, Mr. Chair. Thank you. Thank you very much, folks.
Councillor Vanbeck.
Well, thank you very much. And I just really wanted to take this opportunity to say 2 things. Number one, thanks for all the work that you're doing with the strategy overall and the various programs. But secondly, just comment on the CTS, because I think, as folks know, this was a very lively topic prior to it being introduced. There was, concern in the community of what its impacts might be, and as suspected, the impacts in the neighborhood have been nil to negligible, and the impacts on the lives of the individuals who are using it as a healthcare facility to deal with the challenges that they're dealing with have been significant. And in my mind, there's no doubt that many lives have been saved as a result of its existence. And while I understand and concur with Councillor Craig, the problems and the challenges throughout the community are greater that we need to deal with. In the long run, every facility like this that we can get open, and I know that work is underway in Cambridge right now to get the second one open, ultimately will help as many individuals as can be provided for in those facilities. And so I just want to thank all of you for the work that you're doing on behalf of certainly our community. Thank you.
Chair Redmond.
Thank you, Chair. You have collectively and individually sort of answered some of my question, which is, what do you see as the barriers? And I hope that you see this as a safe place. Everybody around this horseshoe has expressed the admiration and the value that we see in all of the work that you do on behalf of the community. So if you were going to identify barriers, would it be funding? Would it be cross-funding from different levels of government, maybe different departments? I guess I would just be really interested to know what we as a collective could do. Councillor Shantz sort of hit it on the head. I think that we approach this as a systemic response because it's an all-of-community response. So I'd be really interested to hear from you what barriers you could identify that we might be able to help remove.
Thank you for your question, Councillor Redmond. From Sanguine's perspective, I think we see several barriers. One is that often when projects are funded, they're funded in a pilot way. And so we're in a continuous process of searching for grants and other sources of revenue to continue our projects. Even our Safer Supply project, while we received an extension of funding, we don't know what will happen after next year. And because of the limitations upon that funding, we're only able to serve the number of people we're serving right now. We know that we have lineups of people waiting to access our Safer Supply program every month, and we have to turn people away. In terms of supporting staff, we know that this work takes a toll on our frontline staff, and we don't have adequate supports right now to properly support the staff who are doing this work, and that applies not only to Sanguine, but to shelter staff, staff of other organizations who are working in housing, working in shelters, who are responding to overdoses on a regular basis. So we need to find ways to collaboratively build resilience and support for the staff who are doing this work. In terms of our ability to meet the need, we see that there are so many other solutions we could be offering, but we're limited by our ability to access funding for these. And we see that support from all levels of government is needed, federal, provincial, and local. So that's just my brief statement about that. I'll turn it over to Eugene.
I'm not Eugene, but I'll just add too, and I think we've all touched on it here, but a huge part of it is the fact that at the end of the day, a lot of the, from a bigger picture kind of policy level, that this lies at a federal level, right? And I think that is a huge barrier, at least at this level of government, is that there's only so much that can be addressed by these chambers. So I think part of what we did with that previous position paper was trying to find advocacy roles of, I know out of that position paper, letters were sent to both federal and provincial levels of government to play that advocacy role, because I think that is also a huge factor at play here, right, is there's only so much that can be done within the municipal powers, and a lot of this power is lying in other levels of government, so being able to advocate for changes on that level.
And I'll just wrap up by saying I think advocacy is our strongest, the strongest tool at this table. We sincerely appreciated when we delivered the position paper in May of last year. This council adopted the recommendations and sent those advocacy letters. I also, as chair of the RID, sent kind of mirroring advocacy letters to the provincial and federal levels. So it really comes down to advocacy for funding and changing in regulations to allow some of the expanded services that we've talked about today.
Okay, Councillor McCabe.
Thank you, Chair, through you, Chair, and thank you to the staff in the for the presentation and the work you continue to do, and thank you to previous council for supporting and doing the tough work necessary to get the CTS site established in Kitchener. As Councillor Urbanovic said, it's having a huge impact, and hopefully we will be able to. We'll get permission to open another one, and on the Sanguine piece, I certainly hope that the federal government and the provincial government come to the table in their upcoming budgets to provide the funding that you need. But my questions, I have a couple of questions. One of them is sorry, I'm having a little trouble breathing. In the prevention work that's happening, do you, in the outreach that you're doing, are you involving all the the school boards and the post-secondary institutions? And I'm just also wondering how you work, or if you work with some of our local groups in terms of some of the education work that you're doing, like some of the groups that the cities have connections with through our, through some of our neighborhood groups or our recreation programs and things like that. So just wanted to get a better sense of how you work with some of those organizations. Sorry.
Sure. Thank you for the question. For some of the prevention work that's been happening, we, through public health and in partnership with RIDS, we have been able to provide some resources to our school boards that provide information related to substance use and prevention. And some of that also came from we were previously talking about the OMARS alerts, and there was an alert that was related to schools, and that helped to prompt a partnership with the school boards. We've been doing quite a bit of work related to more of the legal substances, so cannabis, tobacco, and vaping, because those are some of the concerns with some of the partners that we work with, recreational partners that we work with in the community. So we've been doing some work with them, but through the RIDS, some of our goals is to work collaboratively on some additional prevention projects.
Okay, thank you for that. I just would maybe remind you that there's some significant connections that cities have, or I don't want to speak for everyone, but at least that the city of Waterloo has through some of the groups we work with through our recreation program might be of interest. And my other question is, with all due respect to the report, I'm just wondering about, it feels to me like it's more a summary of activities. So I was wondering about, targets that you had in an implementation plan going forward. I didn't see that in the report, so I'm wondering if you could talk about what you're looking, like targets you have and goals you have, and implementation plans you have for going like from now until, I don't know if it's a year, 2 years, 3 years out? Thank you.
Is your question related more to some of the RIDS work or for some of the public health work?
Oh, sorry, for the RIDS work.
Oh, sure.
Yeah, so I can take that. So as I mentioned in the presentation, we recently shifted to this project-based model, and by recently I mean January of 2023. So we've really kind of changed the way that we're operationalize that work. So we're still in that initial kind of re-engagement process with our partners to suss out the current priorities in the region. The original document that the drug strategy was formed around is, as I mentioned, from 2011. So obviously we are in a very different landscape now. The needs do look different. And then in addition to that as well, right, coming out of the pandemic, we know that largely shifted the landscape we are in this area. So right now we're currently in that re-engagement stage to kind of suss out what the plan will be going forward, if that provides some clarity.
Yeah, I guess, yeah, and we'll certainly look forward to seeing that. And I mean, I think from what I know of the crime prevention happening previously, so I just hope that none of that kind of work gets lost. Because certainly there was a lot of harm reduction work happening through that, harm reduction and prevention work happening through the work that council did. So, and as Councillor, I'm not sure which one was saying that, part of what I'm particularly concerned about too is, I mean, there's stuff that's happening at the CTSs, but then there's also, my understanding is that some of the overdoses happen with first-time users, and that often happens in residence, people's homes. So just hoping that the strategy picks up that significant piece and what might be possible to do about that. So very much all.
Dr. Wong?
I just might add a quick comment. It's certainly, I think, one of the biggest challenges that partners who work on drug strategy are encountering, the number of people who, because of stigma, do not want others to know that they are using and perhaps experiencing problems as a result of their use. And so it is challenging to reach these people. It's important, as you've seen, to be able to offer services to those that come forward. But I think one of the greatest challenges is getting people to come forward. And so I don't really want to speak for the RIDS, and you can jump in any time, please. But I think that's why one of their key objectives going forward, of all partners going forward, is to try to do work to reduce stigma and to reduce people feeling like they need to hide or be ashamed. And so I think that doesn't necessarily result in outcomes right away. But just wanted to add that say that we definitely see that as trying to reach others who may be using and that are not coming forward for service as an important population as well. Thank you.
We're ready to start our second round of questions from councillors, but before we do that, I want to make sure that any councillors who have not had an opportunity to ask a question don't have one. Okay, Councillor Deutschmann.
Thank you, Chair Erb. Just a bit confused on the role of RIDS in relation to public health, and whether it's an independent body or it's a body of the region. I'm not sure, because we recently received a letter from the Drug Action Team that spoke about a community-based and community-led program, and I got the impression from their observations that that's not what is currently happening. I have two questions. I was on the website and I was hoping to see maybe who is the makeup of the RIDS, but I couldn't determine that. But I saw there was a 2018 opioid response plan with a list of participants there. And I'm hoping you will work with the Drug Action Team. I know you've reached out to some. But I hope that'll include someone like Michael Parkinson, who's a local expert on the issues we're concerned about, and I see was one of the participants of the 2018 opioid response plan. My question, though, is on the priorities that you identified. You mentioned stigma, but I see on your website you had a stigma campaign in 2018, and I was wondering, what is the goal of the current campaign, and how does that relate to the previous campaign? And then the other question would be, you have a focus on housing, but I'm not sure what that means through the RIDS.
Thank you, Councillor, and through your chair. Sorry, hope I didn't break it. So I guess to answer your question around stigma, so we, like as Erica said, we just re-engaged our partners and have just kind of launched our new project-based approach. It was our partners who came to the table and said the two biggest priorities are housing and stigma. As Dr. Wang mentioned, the stigma of people using alone in the residences is a high issue. So we don't have, we're just starting to create that plan, that project, those deliverables that we're going to try and accomplish over the next year as it relates to stigma in our community. And there was a bunch there, but yes, I definitely have reached out to the drug action team. We've had conversations. I had conversations last week with Dr. Bardwell, who presented to this council last month. So we're definitely looking to collaborate because ultimately we all want the same thing. We all want to have a safer community for persons experiencing problematic substance use. So those dialogues are absolutely open. And Michael Parkinson was a former member of the RIDS who stepped away on his choice. But the door is wide open, and we'd welcome any collaboration we can. So.
Dr. Wong?
I'll just add, so in response to your first question, Councillor, the RIDS is a voluntary collaborative of multiple partners, multiple individuals, agencies. As Eugene mentioned, public health is one of the partners. Public health has been given requirements by the Ministry of Health to support evidence-based harm reduction initiatives. So the ones that are listed in your report, such as the needle syringe program, and that also includes supporting safe consumption site applications. So there's a number of requirements that we have respective to that, but because there are multiple components to a successful drug strategy, which include other pillars, as you've seen, including treatment, which isn't under the purview of public health, but rather funded by the province. We also have other partners, such as unfortunately one couldn't be with us today from the House of Friendship, but partners that work in the area of treatment and recovery. And so public health is one partner among several as part of the RIDS. And as Eugene mentioned, we are open to anyone who would like to join. It is a collaborative partnership, and many partners do this, in addition to their regular work.
Mr. Chair, I didn't get it. I appreciate that. I didn't get an answer to the housing question that I had, though. Mr. Fenton answered the stigma question, but didn't answer the housing question.
Yeah, I can speak to that. I would say it's probably a very similar in nature response to the notion of how addressing stigma is. We're still just in early days of making those relationships with partners, because especially in this area, it is recognize it's a little outside of what traditionally was the focus of the RIDS. It's not a specific pillar. It's more of this broad issue that is related to all of the pillars. So we're still in that initial process of taking the important time to have the conversations and actually identify the needs and look for those gaps where we can leverage those overlapping interests, knowledge in the community to kind of fill those gaps. But it is still kind of early days of identifying the specific needs that can best be collaboratively addressed. And I'll speak a little bit also more in detail to the stigma part of the question, as well as in this, we recognize that stigma in this area is multifaceted and layered and exists at a multiple of levels from different people with different consequences of how that stigma is held. So even that issue is a very kind of complex thing to come at, and we also want to do so in a way that is meaningful and effective instead of kind of rushing into some kind of, like your typical anti-stigma campaign. Maybe it's bus ads. We know that in order to actually kind of get to the roots of that stigma and meaningfully address it, you need to take a very well thought out intentional approach. And so that's kind of the same process we're going through there is identifying the best collaborative interventions in that domain.
I have two more speakers, Councillor James and then Councillor Craig, and then I think we're going to try and bring this agenda item to a close. Councillor James.
Yeah, thank you, through you, Chair Herb. I'm really concerned about the consumption treatment sites and them not including the inhaling of substances. I'm just wondering, and I don't know if this is the direction through our staff at through public health or as us as Board of Health here, if we can advocate or send communication to the province to include within their funding model for CTS sites to include the inhaling of substances and provide them with just some of the data potentially that you may have, just how much of that is we're turning people away because of that, and to include that within their model, especially because, consumption treatment sites is very broad in its language, doesn't specifically say injection. So using that as an angle to advocate, if our staff could be able to put something together to send.
Yes, definitely. Staff have been advocating to their counterparts at the ministry, but it's definitely something we will continue to work on. I don't know, Jonathan, if you wanted to add anything with respect to that, or.
No, I think that would be helpful for the ministry to know. We do regularly communicate with them about the need, that there is a need, and that they is an unfortunate limitation of the funding that it isn't a part of the funding is to allow for that. So if there is any type of communication that can go additional to what we're already doing, would be helpful.
Yeah, absolutely. And if, potentially council endorses that, but something that really speaks to the need to include this in the funding models to address this in the region. Thank you.
Thank you.
Councillor Craig.
Well, Mr. Chair, I would like to make a comment. I'd also like to make a request of our health staff. May I do that now, or do you want me to wait a little longer?
I don't have any other speakers, so go ahead.
Well, I want to come back to my comments with regards to the report done in 2018, and where it states very clearly that we have an estimated 4,000 people in Waterloo region injecting drugs. And on a daily basis, approximately 2,000. So every day, 2,000. Safe injection site, limited by money and a lot of other things. I mean limited, not by good people, but limited by a lot of other issues, is only seeing 30 to 40 people a day on average. I'm going by the dashboard, okay? So that's about 1% of those people injecting drugs. And I think we have to deal with that. Another CTS site is not going to improve the situation all that much. So I think the first thing, and I'll make this the request, I don't have the answers. Very interesting. I talked to a couple of people well known in this region, and one of them said to me right off the top, I don't have the answers. Well, I don't have the answers either, Mr. Chair, but I think we have to keep probing. But This report is excellent. I come back to it again, and I think all it needs is an update, because it talks about injection drug use in the region, fatal and non-fatal overdoses, naloxone distribution, impact on local health care, et cetera, et cetera, et cetera. And I think this report needs to be updated so we know the probable number of people who are injecting drugs and the extent of drug use in the region. We got a survey, I guess it is, a proxy survey, which is really not relevant at all, okay, in terms of what it's saying. So I'm requesting that of health staff to update the key parts of this study so that we can come back at a later time and talk about a more expansive viewpoint and how we're going to deal with this issue. Thank you, Mr. Chair.
Yes, the need for updated and continually updated data is actually the reason that we created the new online dashboard, or enhanced the data that we were publishing on our website previously, and put it all together into the new overdose drug poisoning dashboard. The data that you received regarding the number of people that are estimated to have drug addictions is based on the best available data that we have from data sources, that have been validated at provincial levels, and that were then further estimated using our local population health data. The study that you are referring to, Councillor Craig, is a specific study that was done in the context of an application for the safe consumption site in Kitchener. And so there were additional pieces of information that were included specifically with respect to injection drug users. That said, our purpose for the overdose drug poisoning dashboard is to make sure that we have on an ongoing basis the most up-to-date data that we have, and we can continuously look to see what additional data that may be relevant to inform our work, to inform the partners' work and the community, to add to that dashboard. But at this time, what is on the dashboard is what is currently available, and that is most recent in terms of data. It is extremely difficult to estimate the number of drug injection users and the number of users in general as well, due to the fact that most users do not want people to know that they are using. And so we have to use proxy measures, unfortunately, that are imperfect, but that give us some sense of the scope of the issue. So it may never be possible to know the exact number. Just to provide a bit of context around the limitations to those types of estimates. Thank you.
I'm trying to understand this, Mr. Chair, the dashboard, there's a number of dashboards out there, so I'm getting confused. We got the proxy statistics, and they're talking about 17,000 residents. Is that acceptable in terms of what we're looking at?
Yes, there's two data sources that lead us to proxy estimates of between 14 and 17,000 people in the community who are using drugs. And so from that, there isn't current data right now that allows us to estimate that into injection, inhalation, oral, different types of consumptions. But roughly, we're thinking between 14 and 17,000. And that data does get updated every 2 or 3 years, and so we will continue to update those estimates as we go forward. Just to give a sense of the issue and the sense of the problems that we may be encountering, but it is extremely difficult to have more precise estimates of the number of people who are using, in particular using in a problematic way, because most people don't want people to know that they're using.
All right, Mr. Chair, I won't carry on because it will become a debate. I don't want that. What I'll do, if I may, at some other future point, is to come back on this, okay? And to raise the issue again in terms of how I'm perceiving it. The information that was out there that was used in 2018 to justify the safe injection site didn't seem problematic at the time. Anyways, I'll leave it at that.
It might be a good conversation to have offline with staff to try and clarify the question. Thank you for the update. You've been coming to us annually for the 5 years that I've been here, and every time there's incremental steps of better things that are happening in the community. You're on the front line in a very, very challenging environment. Thank you so much for what you're doing. I think the words that I took away from what you were telling us today are the barriers that exist and how we have to work to remove those barriers. The stigma that we recognize this and convince the community that this is a healthcare issue, and to try and remove the stigma from it so that people are free to seek help and not be embarrassed by it. And not only the stigma for the individuals who are using, but also for their family members, so that there's a collaborative approach to getting help. So thanks so much for the work that you're doing. You're an inspiration to all of us, and thank you.
Thank you very much for your time.
We're on to item 6.1.3, regulatory changes to the Housing Services Act. Mr. Sweeney is going to introduce this, and then coming to provide some background information, Kellyanne, Ryan, and Jennifer.
Wonderful. Through you, Chair. Yes, as Ryan and Jennifer Murdoch-Martin make their way to the podium to introduce this report, which does come with a recommendation. I'll let them provide some of the material context behind that. I do want to I would be remiss if I didn't acknowledge that they're joined by some of our staff here today. I'm going to embarrass you all at the back to give a wave. In this chamber, at least in my experience, we've often talked on this file about supporting those who are currently living unsheltered, and we haven't had the same amount of opportunity to talk about the significant amount of work, effort, blood, sweat, and tears that goes into the work that we do to support people who are housed, to support them to stay housed in a way that is safe and conducive to a life of dignity. So to the staff who are here to support the team here, I just want to acknowledge all the hard work that you and your team does as well. So thank you. Ryan and Jennifer, you're on the clock here.
Thank you, Peter, and good morning, councillors and Chair Irvin. Thanks for acknowledging the staff that put a whole lot of time over the last couple of years into this report and presentation that is culminating this morning. The changes that we are speaking to this morning are
green tells me it's on. Thank you, and sorry about that. If you could go to the next slide, please. We are here this morning to speak to these important changes, and arguably these are the biggest changes related to the not-for-profit and co-op housing sector since the responsibility for funding them shifted to municipal service managers over 20 years ago. Locally, this sector represents 27 different not-for-profits and co-op entities comprising approximately 3,200 units of deeply affordable housing in this community. All of these units were originally created through various federal and provincial agreements prior to being downloaded to the region as the service manager. It is this stock, this section of our overall local affordable housing supply that is the subject of this morning's presentation and report. These 3,200 deeply affordable units operated by the not-for-profit and co-op sector exist across the region, in our cities and in our townships, in a variety of built forms. The issue presented this morning and the subsequent recommendation relates specifically to this one asset class only, and not to Waterloo Regional Housing or the affordable housing that we are creating through our Building Better Futures initiative, where we are incentivizing it through capital grants. Next slide, please. When the region inherited the funding and administrative responsibility for this housing stock from the province, the governing legislation included a complex and very prescribed funding model centered around the operating cost, including most significantly for today, the operating cost tied to the mortgage. And that's the crux of the issue that we are speaking at today. It relates to the mortgages because the agreements that came with operating these housing providers were tied to those mortgages. And from the early 2000s through the intervening decades, the province and the legislation were silent on what happened once those mortgages were paid out, and subsequently the agreements attached to them expired. Last year, the province did release regulations regarding the new service agreement framework for community housing projects that were reaching their end of mortgage. And it's these regulations that have created a new environment and a new opportunity in terms of defining how we work with and administer our partnerships with this sector in the delivery of affordable housing going forward. It is this opportunity enabled through the new legislation that has defined our approach locally to create a new environment where existing providers will not only stabilize their operations and continue to provide affordable housing post end of mortgage, but will also have the opportunity to grow. Developing an approach that protects and enhances the historical investments and existing community housing assets is just as critical, if not more, than creating new affordable housing options across the region. I'm going to turn it over to Jennifer for the next couple slides.
Thank you, Ryan. Thank you. We began to draft our response to the end of mortgage in advance of the new legislation. Foundationally, we needed to create a strategy with a system-level approach that is responsive to the unique needs of providers, the stewardship of the system, and the clients we collectively serve. Our response to EOM is the Community Housing Succession Strategy and the three pillars approach, an approach that seeks to seize the opportunity provided and look at it as more than just the mortgage's ending, but looking at it as an opportunity to move from a compliance-based relationship between the housing providers and service managers to one of capacity building and growth, and making informed decisions while preparing for EOM. The strategy has three core business functions, and the work between them is interdependent. The core functions are engagement with housing providers, a local advisory committee, and creating the policies and tools to support the work. Next slide, please. The strategy is a holistic response intended to set a path for service managers and housing providers both pre and post EOM. We'll focus our work in partnership with housing providers to understand their vision and to work together to determine how the region can support the achievement of that vision and how they can continue to offer affordable housing in Waterloo Region through service agreements. We will leverage the insights of our Provider Advisory Committee, the CHEER, as a centralized location for dialogue and feedback between the region and community housing providers. The strategy is currently limited to the 27 provincials and nonprofits, but it does incorporate future growth in the sector. Next slide, please. As community housing providers individually experience their EOM over the next several years, the succession strategy becomes our guide to achieving the goals of a connected and responsive system, one where providers are actively engaged and where continuing to offer community housing is the preferred choice, a housing system that demonstrates good leadership and good stewardship of the longstanding public resource and assets of community housing, a good and viable, sustainable partnership through responsible financial planning, sound asset management, and good governance. And also setting the stage for growth in the sector to address the ongoing need for affordable housing while remaining client and equity-centered on the policies and programs offered and developed.
The new regulations have provided a framework with the flexibility for service managers to shape the community housing system in a manner unique to our communities and to continue to meet the needs of providers that provide homes now and for future generations. Working with our partners in this sector, we want to take this as an opportunity to continue to collaborate in shifting the relationship from the inherited compliance model to one of capacity building. We know that each provider is unique, and we want to customize our services and supports to achieve our mutual goals. We believe that the work and approach being proposed in implementing this strategy will have a positive and generational impact in this region that will shape the affordable housing landscape for the decades to come. We're at the beginning of this work, and we'll need to monitor, evaluate, and adjust as we grow into this new reality. But now is the time to get it right, to continue to invest in these valuable community assets that provide affordable homes to over 3,200 families currently and for the future. Thanks for listening.
Thanks, Jennifer and Ryan. Are there any questions? None. It's nice to see some of the initiatives that are taken in this, particularly under the where they're allowed to build up some kind of reserves and the partnerships that you're developing with the people in the units and the co-ops where they're living. This is as an action item, so I need a mover and a seconder. Moved by Councillor James, seconded by Councillor Foxton. Any questions or comments? All those in favor? Or, yeah, I'm sorry, e-scribe. Pardon? So are you in favor? You can so indicate on the e-scribe. Is it showing up? It's not here on my screen. All in favor? Carried. It's carried. Thank you. Item 6.2, a response on, correct? Oh, I'm sorry. Missed Mr. Sweeney here, interim housing update. Mr. Sweeney.
Thank you. Through you, Chair. Again, just my regular monthly verbal update on the ongoing work related to our interim housing plan that was approved by this council back in August. Just a couple of relatively quick updates that are timely in nature. The first is that the work that we are doing in partnership with the House of Friendship and their new shelter care model and the new facility on Weber Street. The facility is open. As I believe I mentioned at the last meeting, the plan was always to provide an opportunity for the House of Friendship and the folks that would be served there to have a bit of a rolling access. So the first priority group that was identified were the residents who are currently living on Charles Street, and so those folks have all moved into the new shelter care. The next cohort was looking at those who needed accessible units. That work has been done. So I'd say at this point, we're just over about a third of the way full, that full capacity, and over the next couple of weeks towards the end of the month, they will be rolling towards full capacity there. The second update is with respect to the shelter on Herbs Road. We continue our efforts to have open, transparent, constructive partnership dialogues with all stakeholders. And just last night, some staff met with some neighbors who are directly adjacent to the property to continue those conversations. There will be public tours on offer. I don't have a date yet, but stay tuned both for public and also for council. I want to acknowledge the significant time, effort, and priority that has been put on this by both our housing staff, but also our colleagues in facilities, and Dave Powelko in particular, who we asked to make this a top priority and responded. And you might recall at our last monthly meeting, there were a couple of significant sort of milestones that we needed to hit to be able to open this. And I'm pleased to report that all of the significant milestones have been addressed. We had some worries about provision of electrical services. That's been taken care of. We had some timeline delays with CSA on the building of the community space. We now have those approvals in place. So as everything I'm being told, we're moving fully ahead. We will likely have substantial completion and ownership by the end of the month as we've promised, but it is going to take a little bit of time to get that community space set up and some other sort of minor things. So we're targeting April 15th as a full move-in date. I will also report that our partners in the working center have and our housing staff have been working to finalize that operating agreement, but also the working center is fully engaged in connecting with the unsheltered community, particularly through, you might remember, we supported financially the delivery of winter warming kits across the community, and so the staff at the working center used that opportunity to identify, confirm folks on our by name list. And so work has been done in earnest to identify people who would be a good fit for our new shelter on Herbs Road. And so that work is well in hand. As again, you might want to appreciate, however, offering something like this to somebody on March the 7th, may shift by the time the actual opportunity comes around. And the other thing we're still working through is, the logistics of offering a space that's new to this community, relatively new in the context of service system manager. So we want to be really dignity and compassion focused on how we actually support physically providing the opportunity for people to choose to come out and live at Herbs Road. And then I guess the final update is just not to lose sight of, the intention behind the interim housing plan was really to put some key pieces into place as we continue to work through the development of our end to chronic homelessness plan. That plan is well underway with community partners and setting up that work that will come back to council in a number of points along the journey to update you on how that's going. And, obviously the addition of transitional and supportive housing is a really important element to this plan. So you'll recall, we've talked about the Rapid Housing Initiative, so we're finalizing some work in that respect. And the other item I just want to reiterate is we talked a number of times through the budget process around the Building Better Futures, the Waterloo Regional Housing Master Plan, the 2,500 units over 5 years. So staff and I have connected through those conversations, and we are conducting a sort of a mid-project review of how we're doing relative to the goal. And we will be coming back to council sometime later this year with a bit of an update on that plan as well. So there's lots going on that is very, very timely. So again, thank you for the flexibility for me to provide this monthly verbal update. Thank you. I'm happy to answer any questions.
Thanks, Mr. Sweeney. Any questions? Okay, this update was for information only, so no action required. The next report is 6.2, the implementation of a medical priority dispatching system, and Mr. Riches, the Director of Paramedic Services, is here to speak to this along with some colleagues. Mr. Riches.
I'm glad Ryan told me about the green light. Thank you, everybody, and through you, Mr. Chair. I'm here today to give you an update. There was a report we submitted through eScribe for council to read about our dispatch model through the Cambridge Central Ambulance Communications Center. Before I start, I'd like to introduce Commanders Ed Bezinchek and Mike Martin, who are our operational managers for our day-to-day 911 operations. And if we get MPDS at the Cambridge CAC, they would be primarily responsible with updating our entire deployment plan to allow for better and more timely response by paramedic services to our increasing 911 call demand. So it was important for me to have them here. The challenge with, so council knows, and when I was here before, We talked about maybe giving you a quick update on how the dispatch model works, and then this report came up after speaking to Commissioner Wong and CAO Lochner. So to give you a bit of background, next slide, please. The province directly operates our CAC, we call it CAC, it's the vernacular, but Central Ambulance Communications Centre, and it's out of Cambridge. And the Cambridge CAC processes and dispatches all 911 ambulance calls for the region of Waterloo, Guelph, Wellington Paramedic Service, and Dufferin County EMS. So it's a fairly large geographic area. That's not unique to the province. The province runs 22 directly operated CAC centers throughout the province, and in some CACs might dispatch as many as 4 or 5 different paramedic services as geographic area, and some might only dispatch one. Not all CACs are directly operated by the province, so Toronto runs its own CAC center and gets funding from the province, and Niagara, same scenario. The rest of us are subject to the Ministry of Health Central Ambulance Communications Centre operations. The current call prioritization system that the province uses in its CACs is called DPCI-2, or Dispatch Priority Card Index 2. So we just call it DPCI. The challenge with that system is it's old and antiquated, and it greater than 80% of the time, our medics respond to calls on a lights and sirens basis. So 80% of the calls that come in through the CAC center end up spitting out a code 4 response, which means our paramedics have to run lights and sirens. When the reality is we know not 80% of 911 calls are for acutely ill or very sick people who need our immediate response. So that's the background for council. I hope that that helps for you. We also know that we don't transport every 911 call that we respond to, but for the patients we do transport, only about 15% of the time are the patients so sick that our paramedics elect to transport those patients to hospital on a lights and sirens basis. So we call that over-prioritization in the business when I'm speaking to the other chiefs. So the DPCI system has a high over-prioritization rate. And so that's kind of your background here, and that's why it's important for council to understand. Next slide, please. So a couple other challenges for background. The current system is very rigid and does not support reassignment of code 4 responses. So because 80% of the times we run hot or lights and sirens, what that means is a crew, when we have reduced resources in the system because of offload delays or any other challenges, a crew that's sent to one code 4 can't be reassigned to go to another code 4 that might be for a sicker patient. So the system doesn't allow for it. The crew is assigned to the code 4 that they get, and unless that call gets canceled by the caller or another resource gets there first, in the event we send more than one resource, that crew's got to go, even when there might be another code 4 that comes up for a sicker patient. So basically, a code 4 is a code 4 is a code 4. Doesn't matter how sick the patient is within that code 4. If it's a code 4 response, they've got to go. So that's one challenge. And then the other biggest challenge for us is it has a significant impact on our day-to-day operations. So we want our resources to be available to respond to our sickest patients, our patients who have the most need for our expertise and services and to stabilize their situation. We want to make sure the right resource gets to the right call at the right time. And we want to manage our paramedic rest periods and their end of shift. And the current DPCI system doesn't allow for that. We can tweak our current deployment plan, and Ed and Mike work hard to come up with different tweaks to try and nibble around the edges. You may have heard me say that last time I presented. But the reality is, without a massive modernization of the dispatch system, we're really stuck with the dispatch system we have, and there's not much we can do. The other piece that's really important here for our frontline staff, and you'll hear me say this time and time again while I'm here, is we need to support our staff to making sure they get their downtimes and their rest periods, and we need to make sure they get home on time. And the current DPCI system doesn't allow for that, so if a crew's in their last 30 minutes of shift and a code 4 comes up, even if that code 4 is not a very sick patient, the crew's got to go, and now they're not getting home to their families later in the day, and that may or may not be for a very sick patient. So just like the hospital system prioritizes and triages how quickly someone gets care based on their medical needs, we need a dispatch system that does the same thing. The good news is that the province did commit in 2019 to implementing a new dispatch system called MPDS. And MPDS, or Medical Priority Dispatching System, is internationally known. It is a very effective system. And its over prioritization rate, and you heard me say that term earlier, so I'll be kind of quick here. Every dispatch system has some over prioritization. There's some risk management built into it because you can't 100% guarantee that what the caller's telling you at the 911 call is 100% accurate. So, but the DPCI system is about an 80% over prioritization rate. A fully mature MPDS system is about a 40% over prioritization rate. So that means that we can cut in half the number of, our paramedics will still respond to calls, but they don't have to go lights and sirens to those calls. And what that means is when patients are really, really sick, we can reassign people more effectively to the sickest patients. So that's important as well. And the province has committed to implementing a new dispatch system. And the other thing that I personally value, and I know our team values, is the MPDS system has medical oversight. There are physicians attached to it who sign off on the system, and it's evidence-informed decision-making that determine patient determinants and the priority it spits out and things like that. Next slide, please. So our assessment is MPDS is a better system, it's more efficient, and it helps manage risk effectively, which I know is important for council, and as it is for me and my team. Lower acuity patients under MPDS can be determined to safely wait when our system is busy. So when we get into what council well knows as code reds or code yellows, when we don't have resources, what it means is the lower priority patients can be told that, yes, we'll get to you, but you're gonna have to wait. And that's okay, and I want to assure council that that's an appropriate way to manage our resources and to manage patient expectations. And what I want to clear up for you though is if we have lots of resources in the system, we'll still respond right away because we have lots of resources in the system. It's when we're in our code red or code yellow scenarios that we want to be able to hold crews back effectively and safely so that they're there for that next really sick patient, which that call is coming in no matter what. It'll come in at some point. In December 2022, the province implemented the MPDS at the Mississauga Central Ambulance Communications Centre, which deploys the ambulances from Halton Region and Peel Region. And in speaking to their leaders, early information, and it's very, very early, they're doing a lot of study, is showing improvement in all key areas, less code red incidents. Now, they don't call them code reds in those regions. I think they call them code zeros or code criticals, but same principle. Less missed meal breaks and rest periods, less missed rest periods for our staff. They need downtime between some of these really high stressful calls, and they're not getting them currently here, but out in Halton and Peel, they are seeing some improvement in that, and less end of shift overtime, which actually results in less cost to run our system. Because if we're paying staff overtime, they're getting paid more to work longer, obviously. And it's more, and also really important for our staff's frontline staff's mental health and well-being that they do their 12-hour shift and they go home and they get a chance to decompress before their next 12-hour shift. When they get into a 13-hour shift or a 14-hour shift, that weighs on them. Next slide, please. In 2023, what we're aware of from the province is that they're going to implement MPDS at the Georgian CAC, which is York Region and Simcoe County, and then Thunder Bay and Kenora CAC way up in the north. And the remaining schedule at this point is uncertain. The current information I have indicates that this is pre-pandemic when they did publish a schedule, that the Cambridge CAC would occur, implementation of the Cambridge CAC would occur after the other CACs in the southwest part of our region got implemented. So basically we're in a holding pattern, and you're hearing me tell you that this will be a massive improvement to our system. And so that's why I'm here today with council support. Next slide, please. So some challenges and issues that I'd like committee and council to be aware of. There are, when you have a DPCI CAC beside an MPDS CAC, those two systems don't communicate very well to each other. And we have a lot of cross-border sharing of resources and calls that come in because when people call 911 from a cell phone sometimes, they may be calling in Guelph Wellington, but it pops up in the Cambridge CAC because of cell phone towers is one thing that could happen. Or if Guelph Wellington is really, really busy and we aren't, then we're gonna go in and try and help them in their area as an example. But when DPCI systems and MPDS systems are trying to call share, it doesn't work very well. And I have direct experience of this from my previous job at the Region of Durham, when we used to support Toronto, which does use MPDS. So, you know, it just creates challenges. And so what is currently a code for lights and sirens under DPCI might under MPDS be a low priority which means that we might not be getting support from our neighboring areas in the timely manner that our current residents are used to it in our dispatch system. So there's some issues there. And as I mentioned already, the continued use of the DPCI system does not allow paramedic services or us and my team to implement strategies to get the right resource to the right patient at the right time, reduce our code reds and yellows, which I know is a priority of everybody here, reduce our missed rest periods for our staff, and reduce end-of-shift overtime. We are doing what we can within the current system to mitigate those situations as much as we can, but what we really need is MPDS to come to the Cambridge CAC Centre. Next slide, please. So I guess I'm here, and the report for everybody is, it's an advocacy request of council and committee and Chair Redmond to work with our partners at Dufferin County and City of Guelph and Wellington County to develop an advocacy strategy to basically push the province to implement at Cambridge CAC sooner. And that would include, my role as the chief to meet with our local MPPs and elected officials and also council support in that regard. My experience is, and my understanding is that the squeaky wheel gets grease. And so I think it would be really smart of us, and I've already talked to the chiefs of the other services that we're all going to push hard locally to get our MPPs to listen. But obviously the more political pressure we can put on the province to implement this sooner, the better. And that would be my comment and question to this, and I'm happy to take any questions if anybody has any.
Thank you, Chief Riches. Councillor Foxton.
Thank you, and through you, Chair. Actually, that was my question, was did you want us to advocate for you?
Yes, please.
And if we do, I would like staff to maybe present us with a brief, because I have a meeting with my MPPs this coming week. And also maybe to the ministry.
Yeah.
We should advocate. Through the township, direction to staff or a motion, Madam Chair?
Through you, Chair Erb, I think a motion provides extra added strength, but certainly we'll take this through the AMO channels, FCM.
So I will so move.
Yeah.
Thank you.
Yeah.
So we want to be more specific or get something up on the screen that we know what we're voting on, or is it simply? Sorry. Do we have anything that we can put on the screen, Aaron or Julie?
So basically, we're asking that the upper levels of government move forward with the system to reduce the extreme calls, because they're not called red. So we want a word that would match what you're called. So
if I may.
The system that would prevent the.
Okay.
Yeah.
Yeah.
If I may, Mr. Chair, through you.
Go ahead.
I think what we'd like to see is a statement that asks the province to implement MPDS at the Cambridge CAC as soon as possible, something like very simple along that lines. Because to be fair to council, I've asked for when is the timeline, when we are getting implemented, and the ministry has not provided an answer and is being very quiet to all the chiefs about that across the province.
The first statement there, the paramedic service senior leadership requests, and we recommend the following approach of action. I don't know if I want that in the motion. Just that Regional Waterloo continue to engage the ministry on, not only that, we want the action in the motion. That Waterloo region and our paramedic services essentially need this program now, and we are advocating on their behalf.
Okay, everybody clear on that? You're okay with that, Councillor Hudick, as a seconder? Okay. So we'll deal with that now before we deal with the other speakers, I think, if that's okay. All those in favor? Yeah, no, I was wondering if we would deal with this motion and then we'll get back to the questions? Or procedurally?
My question was about the motion.
Oh, okay.
Yeah.
All right, okay, well, all right.
And maybe others are, I don't know.
All right, well then let's go to the other speakers then. Now, Councillor Harris.
Yeah, thank you. Well, thank you, Chief. Obviously, for putting this at the top of your list in your new role as chief. This is something, frankly, that our community has been at the forefront of for decades, likely. I mean, I recall in the last several years, we've written to the minister. I've asked that it be included in our annual ask of the government in terms of a budget ask in terms of high priority with this council. I know when the chair writes a letter to the government on that note. I think it was in 2002 when they actually, it was at least 20 years ago when they allowed Niagara to bring in this pilot project to study this, MPDS. There was a lot of controversy on that for years subsequent. It was an accident at the airport, if everyone can recall, that sparked a commissioner report led by the former police chief, Larry Gurville, where we all kind of came together. Now, there's a separate issue, which is the regionally managed dispatch, which is similar to Niagara and Toronto. I believe Muskoka is as well. Are they not? Muskoka doing their own thing?
Most others, no, my knowledge is Niagara runs its own dispatch, as does Toronto, and everywhere else is a directly operated Ministry of Health dispatch center.
Yeah, I will say it's unfortunate to see, look, there's no doubt those other communities like in Peel and Halton are deserving of this as well. I know, even our former paramedic chief was hot on this issue as well, and I believe is still involved in Southwestern Ontario's advocacy for this issue. But I suppose they've not gone to regionalization. It's still a provincially, run operating center. So
that's correct.
We don't want to cloud, I guess, the second ask or, of us doing it ourselves with our other emergency service partners. But, I would be, and I don't know if this motion speaks to, obviously it's our advocacy, but I don't know if you'd mentioned that you are prepared to meet with our MPPs, and I would even go and say to you that I would be 100% supportive of that. I mean, there's obviously things we can do in writing letters and politicians speaking to other politicians at different levels, but I think you and a delegation, whether it's our own EMS folks or a partnership with other chiefs in these surrounding communities, go as delegations. And I can think of one particular important delegation you could do over in Dufferin County with, in fact, that member of provincial parliament who also happens to be the minister. So I'm hoping, I don't know if you need formal consent from us with this motion to allow for that to be done, but maybe you can speak to that further, because I'd be extremely supportive of you and whoever else you feel from Waterloo Region to do that on our behalf as well.
Thank you. And through you, Mr. Chair, I appreciate your question, Councillor Harris. The advocacy is, as you've already pointed out, a top priority for myself and my leadership team. In talking to Chief Reed from Dufferin County and Chief Dewar from Guelph Wellington, it's a number one priority for them. All three of our services stand to benefit the most from early, because we all are run by the Cambridge CAC. I would agree that the MPP for Dufferin County, who's the Minister of Health, should be someone we're directly advocating with. And that is an ongoing basis. Definitely is appreciated that council and councillors are supportive of that work. I know in speaking with Chair Lochner and Commissioner Wong that, it's part of their work too when they're doing some government relations. But, my intent is, as I mentioned, to be pretty noisy on this issue. I will tell council that my understanding of how the Mississauga CAC Centre was chosen first was because their councils and their chiefs and their local elected officials were really noisy and said we wanted to go first. And so the province said, fine, you can go first. That's my understanding. So to steal a page from their book, I think is kind of my approach in this regard. Thank you.
I'm with you on that. We have long wanted, been advocates of this issue. It's obviously working in Niagara and those communities. So whatever we can do, Chair, here to bolster the letter, to action again, not only our chief, but our chair to send off a letter to include it on that annual correspondence that we have as a top, tier issue in our community. We've all read about, all the, EMS issues that we've had, frankly. I mean, look at the expansion of our EMS services through our budget with the hiring of new paramedics, new vehicles. We read about the offload delays and Code Red and all these other things. This system, and I mean, who knows? We're talking decades of MPDS. What'll replace it? There'll be something new by the time it'll come around to us potentially. But this has to be a high priority for us, our council, and I'm very thankful that Chief and you and your team have made this a priority. Huge, important, very important. So thank you.
Councillor Unick.
Through you, Chair Erb. Thank you, Chief, for your excellent report and your excellent presentation. Similar to Councillor Harris, I'm happy to support this and push it forward with you. I guess my question is around the fact that this report is so good and the evidence is there. So do you have any idea why MPDS is not being universally implemented? I think it makes good sense in terms of lives saved and finances. So what's going on here?
Through you, Mr. Chair, thank you for the question. It's kind of a loaded answer, but the province has committed to implementation of MPDS. I want to make that clear to the 22 directly operated CAC centers. I think where I sit with the other chiefs in the province through the Ontario Association of Paramedic Chiefs, and that's our provincial lobbying organization, and so council knows this is a number one priority for that lobbying organization as well. I think we all have been, we all wish this was happening at a much quicker pace than it's happening, is the best way to put it. I've been a paramedic, or in paramedic services, my 28th year. And when the services got downloaded to the regions in 2000, back then, this was a priority issue in 1999, 2000. And I was told by my original chief that it would be implemented within 5 years. And here we are in 2023, and I'm asking for it to be implemented. So there's a lot of different reasons. I will say for our Ministry of Health colleagues that the current system they're using, it's not a flip of the switch where they can just do a DPCI one day and MPDS the next day. It's a huge training component for the ambulance communication officers who work in those centers because it totally changes how they process every single 911 call that comes in. So it's not a simple implementation. It has to be done in a kind of a systematic way. So that would be my other comment about that. But I would say that we need this to happen yesterday, to be fair.
I still think it makes better financial sense and better system sense, but thanks very much.
Councillor Veranovic.
Thanks, Chief, for the presentation and the good work on this. It clearly is an important issue and great to see it prioritized. I guess the question I have, just so that I better understand it, so right now, when the Code 4 comes in, I get the part that you can't reprioritize, but is there not within the existing system the ability to rank what's coming in as a Code 4 or Code 3 or something like that? Like I'm just, I'm not asking you to go into a whole lot of detail, but just so that we better understand that piece of it.
Yeah, and through you, Mr. Chair, and thank you for the question. When a 911 call comes in and it goes to the Cambridge CAC Centre, they ask a number of questions based on the cards. That's why it's called the DPCI system. And depending on the answers on those cards, that card spits out a priority. So if it spits out a Code 4 response, that's what gets assigned to our resources. And it can't be reassigned to a Code 3 unless there's some other substantial information that changes or improves. So one example might be if one of our rapid response units got there first and determined that the patient wasn't as sick as originally indicated, then the transport ambulance who's coming could then be downgraded to a Code 3 in that case. The real challenge with 20% of the time we're doing a Code 3 or a Code 1 or a Code 2. So those calls are not the ones at issue. It's 80% of these calls come in for our staff as code 4s. And that means that someone who's suffering a stroke is a code 4, should be a code 4 response, but it also means that someone whose issue may not be that acute or that sick is also getting a code 4 response. And what it means is I can't reassign the second type of call to the stroke call, even if the stroke patient is sicker, if that makes sense to you. Does that help?
Yeah. So with the new system then, would a code 4 still be like a 4, essentially a 4A and a 4B, or would it become like
the new system, to be real, through you, Mr. Chair, and for you, Councillor Van Banovic, the new system goes from a 4-priority system to a 5-priority system. And I won't get into the details of what they're calling the priorities, because that'll be another report when we do get implemented. But the new system has over 1,800 patient determinants within the system. And so the combination of those patient determinants spit out a priority. And what it means is patients who we're currently used to responding to on a code 4 will come out as a lower priority on the dispatch side. And so how that helps us is we're not doing lights and sirens responses, as I already mentioned, and it means that we can safely tell patients when we're busy, you're going to have to wait. And that's the experience that Councillor Harris brought up about Niagara. That's exactly the experience our Niagara colleagues are seeing, is they can safely say, with a good risk mitigation strategy in place, we're going to get to you, but we're really busy, so you're going to have to wait. Right now, it's everybody just goes lights and sirens to everything, which creates challenges for us.
For sure. And so probably the best way of putting this at the end of the day, if we go in this new direction, that the sickest people who need the quickest help are going to actually be served better in the community.
Absolutely, through you, Mr. Chair. MPDS is all about getting the right resource to the right patient at the right time. And sometimes for the lower acuity patients, the right time might be delayed, and that's okay.
Yep. Okay. Thank you.
Thank you.
Councillor McCabe.
Thank you. Thank you very much, Chief, for the presentation. And also thank you for the work that you and your team is doing on the call diversions with mental health. That's really fantastic to hear too, and I really appreciate understanding that, like how proactive you're making this service. So thank you very much for those efforts. My question was just about the motion, and wondering if we could insert a dollar figure. If we have a dollar figure for approximately what this might cost and what this might save in terms of long-term improvements, and whether that inpatient improvements, as you said, getting the right care to the right person at the right time. So that's what my question was. Sorry. I mean, I'm open. It's a friendly question, so I just think having some dollar amounts in there would give it a bit more impact. So, but totally open to Councillor Foxton and others' comments or feelings on that.
Councillor Harris?
Yeah, I mean, obviously.
You want to put your mic?
Yeah, I mean, it's a provincial investment. I mean, it's hard to really I'll let the chief, I'm not answering for the chief, but I mean, I'm not sure if the financial piece, I mean, just for background, I think we're happy that we're no longer fighting over, the, and I always forget it, MPDS actually being the tool we should be using. I mean, it was just up until a few years ago that we were fighting with the previous government to actually, launch MPDS over the DPCI system that was out there, because they weren't willing to adopt or even fund that new system, which I'm very glad that at least they've moved past that debate and fight. So it's now just getting our community at the front of the line to get it implemented. So I'm not just sure how you'd even quantify it financially, other than, we will do whatever we can to support the province's rollout of MPDS in our community, like pronto, ASAP. Like, we will lay out the welcome mat and whatever we need to do. So that would be my input on the financial adding piece. It would be difficult.
Well,
Chief, maybe you want to speak to that?
If the financial part is a bit too difficult to quantify, at least some language that speaks to how patients will be, as the chief said, the right, better served. Like I just feel like the motion doesn't kind of have quite enough oomph to it, right? To say that this is something, there really needs to be some urgency
Yeah, I
and
mean,
priorities given to to this, and what the outcomes would be.
It's a money-saving.
Okay, can we let Chief Riches reply to this? He's been wanting to, and then we do have a motion on the screen now. So first of all, you want to respond to the cost?
Thank you, and through you, Mr. Chair. The province 100% funds and operates the CAC Centre, so there is no financial cost to the region of Waterloo for the implementation of this system. For many, many years, the province decided to download operational responsibility for paramedic services like frontline delivery to the municipalities, of which we receive approximately a 50% land ambulance service grant to run that. But the dispatch centers are directly funded and operated by the province, so there is no cost to the region of Waterloo at this time. So I just wanted people to be aware of that. Thank you.
Oh, sorry, I guess I'm not being clear. Thank you, Chief. I didn't mean, I meant like actually, but I know there's not a cost to the region. I'm just meaning what it would actually cost for them to implement this service. I just wanted to give the motion a bit more sense of urgency and to actually just give it a bit more sense of, you know, what's actually needed to get this implemented. And usually that's money.
Okay, Councillor Foxton, you want to?
Thank you. Actually, not a bad idea, Councillor McCabe, in that the opening statement might say, due to the high volume of calls causing a lack of availability of ambulances, and that the MPDS system is available to alleviate to some degree this situation, then the rest of the preamble, the region of Waterloo. So it said, I said, due to the high volume of calls causing a lack of availability of ambulance services, then go on to the region of Waterloo.
Just to follow up on Councillor Foxton's comments, is it worth also saying that this would be a money-saving, life-saving measure in the long run or the short term, depending on
I don't even know if I want to say money-saving, but life-saving for sure.
Mm-hmm.
The MPDS is a life-saving measure, essential to the service.
I think
And
long
therefore,
term
the
it will
region of
also save
Waterloo.
money in terms of diverting calls and overtime, but that's debatable.
Okay.
Yeah, I mean, I would take that first paragraph and expand on the region of Waterloo, you know, fully supports the MPDS, you know, system for all of these reasons, and you could list a few of them. I mean, they know what they are. We want to reinforce what they are because we're very supportive of the system, but then the second piece is, okay, now we want it, right? So I don't know if it's something between the chief's office and you guys can hammer out, but something at the front.
Okay.
William's usually really good.
So
at this.
can we
You got that,
put the motion up, Julie, in a minute when you're done editing and typing here?
Yes. We're going to buy you a hand massage someday, Julie.
Because again, I think we're thankful that the bureaucrats at Queen's Park finally, you know, agree that this is the system we should be using.
If they agree, they should implement it.
Everyone able to see that?
No. Someone could read it, that'd be great.
So I just want to make sure with Councillor Foxton and with Julie here that we've incorporated everything into it before I read it.
I think so. I think that looks right. Okay, that the regional order.
Okay. That
I would have probably put due to the high volume of calls causing a lack of availability of ambulance and life-saving measures, the region of Waterloo fully supports the MPDS system. Yes. And requests. So I reversed those, the half sentences. Did you get that, Julie?
Should we take a 5-minute break? Pardon?
High volume of calls causing a lack of availability of ambulance and life-saving measures. The region of Waterloo. No, just say, take that out, I would say. The region of Waterloo, municipality of Waterloo fully. Yes, that's it. Thank you.
Mr. Chair, just point of order. I'm just wondering if Councillor Foxton would agree, instead of using the word ambulances, lack of ambulances to available paramedic services.
What did he say?
Instead of using the word ambulances, say replace that with paramedic services.
We want you to put your headset back on, Councillor Deutschman.
Oh, sorry.
I'm wondering if we should. I'm wondering if we could take a 5-minute break here, just to get the language clarified, and everybody can get up and do a stretch. What time are we supposed to start? Pardon? At 11. I think we're missing Councillor Harris, Councillor McCabe.
I'm here. I'm here.
Okay. Councillor Leggett. Do I call it back to order or just, yeah. Okay, I'll call this committee meeting back to order. In consultation with Chief Riches and Councillor Foxton and from the clerks, I think we have something that we're prepared to present, and I'll read it. Due to the high volume of calls causing lack of availability of paramedic resources and the saving of lives, the regional municipality of Waterloo fully support the medical priority dispatch system request that the Ministry of Health adopt a medical priority dispatch system at the Cambridge Central Ambulance Communications Centre as soon as possible, and that the Region of Waterloo Paramedic Services Chief and Deputy Chiefs be directed to continue to engage with the Ministry of Health and the Guelph, Wellington, and Dufferin County Paramedic Services to support this request, and that the Regional Chair, Council, Chief Administrative Officer, Commissioner, and Medical Officer of Health be directed to advocate to the provincial counterparts, being the Minister of Health, the ADM, local MPPs, etc., for the early adoption of the medical priority dispatch system at the Cambridge Central Ambulance Communications Centre. That was moved by Councillor Foxton, seconded by Councillor Hunick. Any other questions or comments related to the motion? Would you then use your buttons on the e-scribe to indicate your voting in favor?
Apologies. Can I just ask one other question? Sorry. As soon as possible, could that be just 2023? Like as soon as possible could mean, like years still from now.
The motion is on the floor, and we've called the vote, so there can be no more amendments to it procedurally. Everyone has voted, so that's carried. Thank you. Thank you, Chief Riches and staff. Hopefully, the conversation and the action will have some results. Thank you.
Thank you. Through you, Mr. Chair, really appreciate the support of council and senior staff on this. It's an important initiative. Thanks very much.
Item 7 on the agenda for information, correspondence, council tracking. Is there any other business? Councillor Craig.
Well, Mr. Chair, it's just a request. During the budget debate, we brought up the issue of a shelter in Cambridge for women. We lack one and one for youth. So I'm wondering if we could get from staff just a very short note on how we would progress to bring that to a reality in the next year or 2 years.
And is that a comment you're looking for now, or a report coming?
No, I'm looking for something in a couple of committee meetings from now. I don't want to put any undue pressure, but I think we would like in Cambridge to start working in that direction. We'd like to know how we start going about it.
Okay, Councillor Deutschman.
Thank you, Chair Erb. Can you hear me? Just want to make sure.
Yep.
Okay, great. Thank you. Just back to the council committee tracking list. I just noted that the anticipated response dates were TBD, and I wasn't.
Councillor Deutschman, I'm just wondering if we can finish with Councillor Craig's.
Oh, I'm sorry. I thought it was done. My apologies.
Mr. Sweeney was going to say something, so I just want to give him a chance. Or am I okay? Sorry.
We're okay.
I'm out of order. You're on, Mr. Deutschman.
Thank you. No problem. No problem. Thank you very much. So just back to on the council committee tracking list, the items were listed TBD, and I wasn't sure if should there be a date or what is. Just wondering what that is all about. Thank you.
Who wants to respond to that? Is that from clerks or Mr. Lochner?
We will review and look to add dates.
Pardon me?
We will review and look to add dates. It's a good point.
Okay. Thank you. Nothing else. Our next meeting is April the 4th. If I could have then a motion to adjourn. A mover, Colleen, seconded by Councillor Salone. All those in favor, use your e-scribe buttons, please. That's carried. 10-minute break? Yeah. We'll take 10 minutes.